can be distracted in that way. It can be rotated across an oblique axis this way. It can be side flexed on the upper side using a caudal cephalic glide in that way. It can be taken into extension by holding around and pushing as follows, and also into a unilateral flexion, side flexion, by coming into this position, encouraging an extension, side flexion motion. The detail of each of these techniques will now be described. In the first case, the standard procedure in manual therapy will be to do a distraction motion. Distraction excluding L5-S1 can be achieved by holding the caudal bone, stabilizing the cephalic bone, utilizing an arm distraction impulse, and resolving this force by the action of the body and the therapist's leg anteriorly. The spine may be held in the standard locking position, or it may be held in the actual neutral position, resting position of the spine. The joint is distracted, and then an impulse in a distractive direction is applied. Because this may be used when there is some tendency to feel that the discal joint is dysfunctional, a slight hold in a distractive position would be advisable to ensure that there is no peripheralization of pain. Because on a standard table with no movement of the table, there is a tendency to slightly open the upper joint relative to the lower joint, it is advisable to slightly distract the lower joint prior to the technique taking place, so that as the impulse is applied, the joint is taken into an equal distractive position on both sides. So having taken up a little side flexion to the left side, then a distraction is applied through the arm and through the body to produce the distractive movement. If this is being done at the L5-S1 junction to use distraction, then the sacral posterior body is engaged using the therapist's upper arm. The spine is left in its neutral position, and then the distraction, resolving the forces through this total therapist contact, is applied, coming into a distractive direction in that manner. Now to apply the individual techniques in detail. Firstly, the use of the locking position will be repeated. The joint is engaged from below upwards with a slight flexion, rotation movement, leaving the joint that is affected in its neutral position. Rotation is applied down to that level in flexion, so that a non-congruent lever is used above, with side flexion to the right, in the presence of rotation to the left, with the whole spine in its sagittal plane in flexion, which is the non-congruent position. To use distraction in this way, exactly the same technique as described before would be used, of engaging the lower joint, taking hold of the pelvis, slight side flexion to the top, and applying the distractive force. With rotation, the axis is considered to be an oblique axis, the axis that allows side flexion and rotation in congruent movements to occur together. Therefore, in manipulation, this oblique axis is recognized. The upper segment is held locked, and this lock is supported by the thumb on the left side of the spinous process. The spinous process of the caudal bone is engaged on the right side with the fingertips. This gives the classical 4-contact engagement of manipulation. 1, 2, 3, 4. The upper segment is held fixed. The body is held close to the patient's anterior aspect of the body so that not too much rotation can be achieved, and a little rotary manipulation is applied like that. The safety is achieved by the selection of the case in the first place, by holding the position just slightly to make sure there is no peripheralization of pain, and then to have the patient rotating with this lower lever into the therapist's body. To achieve a side flexion for this particular technique, the same engagement would take place. The therapist's lower arm on the lower lever now would engage more of a side flexion position, and manipulation then would be in a direction as shown, so that we would move into side flexion and then push down in that direction, causing a caudal cephalic glide on the left side. To achieve a bilateral extension movement, once again using the standard locking position, the joint would be engaged as previously described. Fine-tuning with the lordosis of the spine being achieved would then take place. The therapist would then hold in the anterior aspect of the patient's body to protect excessive lordosis, and a little impulse applied from the posterior aspect to increase the specific extension of an individual segment. To do a unilateral extension, there are certain consequences of this technique that must be taken into consideration, as with all extension procedures. There is a lessening in the diameter of the neural canal, and additionally, when a joint unilaterally is taken into extension with gapping, there is a tendency for closure of the intervertebral foramen. This technique is contraindicated in any case where there has been suggestion of some lesion that is affecting the diameter of the intervertebral foramen, such as a posterolateral protrusion of disc. However, in those patients that have difficulty in achieving extension with side flexion to the same side and no complications of intervertebral entrapment, the following technique is a useful procedure. The classical locking position is used with the lower lever being taken into extension. Fine-tuning takes place with the patient being brought as a whole now into slight rotation to the right on the table, not altering the rotation between the upper and the lower levers. Then the patient can be taken into the manipulating position with the therapist applying the impulse through the posterior aspect of the ilium and perhaps the transverse processes of the caudal bone to give us an increase of extension in a unilateral way, achieving side flexion to the left-hand side. This particular position can be augmented, and probably should be augmented, by the use of a lifting section of the table, which then encourages the lower lever to go into more of a side flexion to the left position. The exact same technique would be used by the therapist. The impulse can be quick but a little less forceful, as the position has been better achieved by the use of the table position. I'll just stop there for a second. In the examples given previously, the lower lever has been used as the contact and the impulse lever. This may not always be desirable, particularly, of course, if there is any hypermobility or instability contained within the lower lever. This means that there is necessity for using the much longer upper lever. In the event of using the upper lever, even with non-congruency of locking, extension levers are far better achieved for rigidity than flexion levers. With the table that we are using at the moment, this is easily achieved. Let us take the example of an L3-4 which is dysfunctional and requires to be manipulated using the cephalic lever. Side flexion in extension will be used, which means that the non-congruency of locking has to be achieved by rotation and side flexion to the same side in extension. It is important that the side flexion is gained somewhat higher than the L3-4 which is being manipulated, because it is the lever that we wish to side flex and not L3-4 which is being left until the final impulse in its neutral position. The table is lifted so that side flexion is taken into the upper lever. Extension is then achieved in rotation by pulling in a cephalic fashion which produces an extension of the upper lever. The lower lever will be handled in the same way as previously, using the ligamentous flexing position of the lower lever. The upper lever is now relatively rigid, but in manual therapy it is considered inappropriate to use the whole length of the lever. It is considered essential to try and use the lower part of this longer lever so that no stress is placed inadvertently on other joints, such as the shoulder joint. The classical 4-point contact would be used with the thumb on the right side of the spinous process of the cephalic bone of the segment, and the fingers on the left-hand side of the spinous process of the caudal bone. The contact with the patient's upper lever now is gained through the thumb, through the forearm of the patient in the lower thoracic wall, and also the body of the patient placed on the lower anterior thoracic wall. The impulse then is achieved into rotation through the upper lever as follows. The lower lever can be further stabilized in flexion by placing a pad underneath the lower lever to increase the side flexion to the left-hand side. This produces rotation to the left-hand side, which makes the lower lever resistant to rotation to the right. And this would be considered a double locking procedure, in extension with the upper lever and in flexion with the lower lever. In the event of the upper lever containing the hypermobile joint, this would be locked in the least stressful position, which would be flexion. And we will give an example of the lower lever being held in extension. So we will ask the patient to turn around and place the head at the other end of the table, still facing me. Same joint, L3-4, will be used, but we will be attempting now to make our impulse on the left-hand side as the patient has been reversed on the table. The classical position for non-congruent locking of the upper lever will be used, of taking the patient into flexion, rotation to the left, which gives side flexion to the right, which is stable now for left rotation. This position can be augmented by allowing the patient to lay on a small pad, so he will be taken back to the neutral position. The pad will be placed under the upper thoracic spine. We will now adopt the similar position of coming into forward bend. That's increased the side flexion to the right in the presence of rotation to the left. The lower lever now can be placed in a more firm position by utilizing the table, taking the leg back into an extended position up to but not including the joint in question. The position would then be fine-tuned by bringing the whole patient's body towards the therapist without altering the orientation between the two levers, and then whatever technique has been designed to give an impulse into rotation, to give an impulse into extension, side bend, both of these two things, or distraction, would be appropriate. Okay. L5 represents a slightly different situation to the rest of the lumbar spine. There is some controversy of the kinds of congruency of movement which occurs in L5, whether it rotates and side bends to the same side in all positions or whether some other variations exist. It is quite reasonable to consider that other variations might exist, with the lack of symmetry that often occurs between the facet joints on either side. However, with the standard anatomical symmetry that is considered, the normally placed sagittal facet joints of the higher lumbar spine have been replaced by a more coronal arrangement of the facet joints at L5-S1. So the obliquity of the rotation thrust shown before is probably now inappropriate and a modification will occur. Instead of using an oblique axis, a longitudinal rotation axis, the y-axis, will now be used. And the thrust will be applied at a right angles to the spine, which will gap the upper facet joint. All of the principles previously described could be utilized, particularly the flexion locking of the long upper lever. This will be placed with a small pillow to achieve a better degree of locking. This will be rotated around, having side flexion to the right side in the presence of rotation to the left side, the whole of the spine being placed in the sagittal plane. The lower lever does not have to be locked because the L5-S1 joint is immediately engaged in the position. So sufficient motion is done to apply a neutral position of the L5-S1. The position is then fine-tuned. The L5 spinous process is locked in the classical position and supported by a thumb placed on the left-hand side of the spinous process, and then the iliac crest is engaged with the forearm. The technique will be to pull the patient with an impulse to achieve a left rotation, but rotation must be managed so that this is not excessive by having a block placed at the front with the patient's hip contacting the therapist's hip. The technique will be to fine-tune and then take up the slack, ask the patient if there's any peripheralization of pain. If this has not been gained and it is appropriate to manipulate, the manipulation is done in a small impulse into rotation. Difficulties with flexion and extension at this joint, and difficulties with L4-5 or L5-S1 being hypermobile and having to mobilize the joint below or above have been considered and developed and refined in manual therapy. It is probably more appropriate to mobilize these particular differences in movement than to do manipulation. Some of the techniques that have been developed by the Norwegian school actually encourage a cephalic bone to be stabilized and then to move the caudal bone into the hypermobile cephalic bone, stretching below the caudal bone. This is achieved in the following fashion. And I'll just stop for a second because we're going to have to change around a bit. Is that okay? All right. To achieve a unilateral rotation, side flexion to the left in flexion, the following technique is useful. The patient is placed over the end of the bed. The legs are gently supported so that the patient does not thrust on the legs, which allows the spine to go essentially into a local flexion position. In the event of moving L5-S1 in a mobilizing way into side flexion, flexion, rotation to the left, the spinous process on the right-hand side is engaged with the pisiform and the hypothenar eminence. The ulnar side of the hand engages the transverse process. So the L5-S1 is recognized and identified. The pisiform is placed on the right side of the spinous process with the ulnar border of the hand on the transverse process, and the technique then would be to move in a cephalic direction on the right hand side, which will produce a side flexion, rotation to the left in the presence of flexion. Stabilization and slightly greater flexion can be achieved by using the left hand to produce a backward movement of the sacrum while achieving the flexion movement with rotation and side flexion of the cephalic lever. This can be used as a manipulation by moving into the barrier and then applying a small impulse at the end of the range. However, this is probably more effective being treated as a mobilization procedure than as a manipulation procedure. I'll just stop there for a sec.
It's almost 8:30.
Okay. One of the difficulties with hypermobility and instability is moving stiff joints in the vicinity. If we have an unstable L4, L5, this would be included in the upper lever to stabilize this, and movement would be then done on L5, S1 to try to mobilize this particular stiff segment. Unfortunately, it is very easy to move the mobilizing force into the hypermobile segment. So in manual therapy, a modification of this classical technique going caudal has been developed by the Norwegian school. This is to take the 5 cephalic away from the sacrum, thus protecting the L4-5 and still producing the movement at L5-S1. This can be done in 2 or 3 ways. Firstly, a unilateral technique, which achieves a flexion, side flexion, rotation to the left, and done from the other side to the right. This is achieved in the following fashion. The patient is laid over the table, supported with the legs so that there is no tendency for the patient to push on the legs. They're encouraged to allow the sacrum to go into an extended position. The sacrum has tilted backwards in that fashion. Then engagement of the L5 on the right-hand side using the pisiform and hypothenar eminence to the right of the spinous process and the ulnar surface of the hand on the transverse process. The technique then is to carry the L5 forward into left side flexion, left rotation, the sacrum being held fixed by the weight of the limbs. This can be further augmented by stabilizing the sacrum at its apex to encourage flexion, opening of the L5 to achieve both flexion and side flexion rotation. This, of course, would then be done from the opposite side. As a bilateral technique, the L5 can be engaged through the spinous process, and then the spinous process of L5 taken forward to achieve flexion at L5S1, sacrum still being stabilized if necessary. If there is difficulty in engaging the transverse processes and the spinous process, a wedge can be used. The L5 is contacted by the wedge, sacrum stabilized, and L5 is taken in a cephalic direction. A variation of this technique would be to hold the L5 in a stable position and just carry the sacrum away from L5. This can be augmented by post-isometric relaxation of the extensors by asking the patient to tilt the sacrum up towards the hand, relax, and carry down once the relaxation of the back extensors has been achieved. Thank you. Okay. As a modification of the classical technique, with patients that are rather larger and a little more taking up of the slack is required, the following modification done carefully is useful. First of all, the setting up of the classical position by flexing up from below and rotating down from above in flexion, using the